Hello, welcome. My name is Priscilla Hudgens, and I am a registered cardiovascular invasive specialist. And what that means is I actually am dedicated to the heart cath lab, and I also have the medical background of it's called limited medical radiology technologist. And what that means is a fancy term for I am not really a rad tech, but I am limited to x-raying this part of your body. So I worked in the heart cath lab for about 7 years, and it's been quite an experience. So I thought I would share a little bit about that, and then you guys can answer questions, send me questions, and I can try to answer as much as I can at the end of the process, okay? Okay, so basically, let's do the next slide. So basically, what does a cath lab do? Okay, so cath lab is a specialized field where we go in and we open up arteries using stents and balloons and things like that. So when a patient comes in for a scheduled or maybe even unscheduled visit, they could be in the middle of having a heart attack, or maybe they're the person that's been feeling like that chest pain at home, that they think, well, I'm just gonna, it's indigestion, that's all it is. I'm gonna, pop a couple of times and then I'm gonna come in. Well, that's your body telling you a little something. So we work with doctors, cardiologists, and in our team of our cath lab team consists of the doctor, a registered nurse, usually a rad tech, radiology technologist, and or someone like me who is our RCIS, registered cardiovascular invasive specialist. So we kind of work as a group, a small dedicated group, to taking care of these patients and opening up their blockages and things like that. I perform a couple of different functions. I actually scrub in with the doctors, and I hand them their materials that they need, their balloons and stents, and I help out with patients' care during the procedure as well. I'm actually qualified to monitor for the cases, which means during the procedure you have your doctor and your scrub tech, and there's also a person behind the scenes, and that person is the person who's monitoring the vital signs for this patient. They're the ones documenting behind the scenes of all the drugs that have been given, all of the stents maybe that have been placed in, and they're watching your vital signs, because a lot of times the doctors and the scrub techs are busy putting these things in, or they're watching wires and how things are going, and they're not really understanding that your blood pressure has just crashed, or maybe your O2 saturations, oxygen saturations, have gone down the tube, and they're not really paying attention. So that monitor person is there as a backup to watch all these intricate goings on and measurements, okay? So what happens, I don't know how much you're familiar and you've learned in your textbooks about heart catheterizations or healthcare in general, but we in the cath lab where I work, we use minimally invasive technologies in order to gain access. So when you come in for a heart cath, we usually go into the right femoral artery. Everybody familiar where that is and everything? Okay, so we go in using a catheter, and actually, you can do this. So we go in using a needle and a guide wire, and then we put in a sheath. And this sheath acts as our portal in order to gain access and feed our catheters in. Now these are all clean, never been used, but y'all can feel and touch them. So what we do is we insert this into your femoral artery here. There's other techniques that we're using now with new technologies, we're able to do this here in your brachial artery, as well as your radial artery. Okay, that's a very common thing nowadays. So here you go, I'll let you look at that if you want to pass it around. So we use that as a doorway to get in, and we have these catheters that we place. These catheters that we have are specifically designed to use for different vessels in your arteries, your heart arteries, okay? So we take this and we feed it through, and it goes up your aorta and into your arteries. Usually this one typically is for your left coronary artery. And through this, the doctor's able to inject contrast through it, and therefore lighting up your whole entire coronary arteries. And we can see instantaneously, we can see any blockages that are happening. There you go. There's several other catheters too, but we won't get into that. The x-ray is coming from below the table. So our patients are on this table, and the x-ray comes from below, and there's an image intensifier that transfers those images, they're called fluoroscopy images, into the computer screen, and what I'll show you in just a little while. So they transfer everything to our computers, and we're able to see it live. Each chamber of the heart gives off a certain waveform, okay? So the person that's monitoring the case can always know where exactly you are in the heart based on what the waveforms look like. So that's really interesting. We can also see if there are any blockages by the waveforms as well. So we always want to take that into consideration and be really careful of that. The other thing that we use to go into the heart is called a pigtail catheter. And our pigtail catheter, just like its name, it has a little pigtail at the end. I don't know if y'all can see that. Now, this is used to actually go into the heart, into the left ventricle of your heart. The left ventricle, as some of you probably already know, is the main pumping chamber of your heart. It gets the blood and it makes that big squeeze, and it's able to pump out through your aorta the fresh oxygenated blood to the rest of your body. So what's important about this catheter is that it can measure, it helps us measure the amount of force that your left ventricle is using, so that we know if your heart is healthy. Because not only can you have blockages in your heart, we may see a patient whose heart is perfectly healthy as far as the arteries are concerned. There'll be no blockages. But the left ventricle is damaged because of maybe a defect, or maybe alcoholism, or maybe some kind of disease that that person had, and the left ventricle does not function like it should, meaning you're not getting the oxygenated blood that the rest of us would usually get, because the squeeze is not as good. So that's one thing that we look for and measure. Okay. Some other things that we do in the cath lab are we look at other arteries outside of your heart. We can look at anything in your arms. There's a lot of people out there who have had renal disease and are on dialysis. Maybe you have a grandmother or an uncle or something that has renal insufficiencies or has a shunt in their arm. And so we take images of these vessels in your arms as well. And your legs. We take care of that, and we actually have stented. Many times we stent legs, arteries in there. The other thing that we do is we put in pacemakers and defibrillators. I'm sure many of you have had grandparents or somebody that you know that has a pacemaker. And this right here, we do two different types. We do a pacemaker, And the definition basically is that a pacemaker makes sure that you're pacing your heart at a regular rate, you know, within a normal rate. And usually that's anywhere from about 60 to 80 beats per minute. And a pacemaker is going to make sure that you hit that. Whatever it is, the doctor puts a range in and programs the pacemaker in so that you'll hit that range. A defibrillator is a pacemaker plus an extra something. And what happens, and this is what a defibrillator is, it's much larger than a pacemaker. A defibrillator actually has a capability to shock you out of a bad rhythm. Sometimes people come in that are very ill and they are in an increased chance for sudden death. For some reason, their rhythm, their electrical system inside their heart is just off. There's many, many reasons for that, but they're at risk. So we implant these defibrillators. So basically, it's just somebody there with you to shock you out of a bad rhythm. You know, that's basically the point of a defibrillator. So you can see it's pretty heavy, and even with technology now, this is the best we've got. It's very interesting. It's quite heavy, as you can see. Okay. All right. So many of you might be thinking, okay, what's going on? How, you know, what about the health care? What do I need to get into it? Am I right for this job and things like that? So, you know, one of the things that everybody needs to think of in healthcare in general, just overall, even if it isn't the cath lab, you know, you need to be thinking, are you, you know, can you be a compassionate, caring person? You know, you do have to have a little bit of that ability in you. Thank you. There you go. You know, it's a nurturing type of thing. Thank you. And so that's one part, you know, of being in the healthcare overall. It's, you know, patients are scared. They really are generally, they may show you in very different ways. You know, one person might not say anything at all to you and you think, oh, she's so quiet or whatever. She's scared to death maybe. The other person is angry and he's, you know, and he's making just a big stink about nothing. Well, that may be his anxieties, you know, and you have to kind of deal with all that stuff. Being in the cath lab, it's a short procedure somewhat. I mean, it can be anywhere from like 30 minutes to 2 hours that you're dealing with this patient. But that's it. So in the big realm of things, it's not a whole lot of time. So within that, you've got to, you know, show some compassion. You need to comfort them as much as you can. And what I mean by that is just, you know, would you like an extra blanket? How about a warm blanket? How about, you know, can I get you this or can I get you that? And just remember that, you know, to you, it's an 8 to 5 job almost. But to them, they're thinking this is so incredibly scary because people are in my heart, you know, and that's what they're thinking. Other things in the cath lab is you need to learn how to be able to conduct yourself during high stress. This job is, you know, it's really nice and neat when your patients come in on a scheduled time frame, but a lot of times that isn't the case. The case is that we take call hours, and you may be wearing the beeper tonight, and you may be called out at 2 a.m. because somebody is in the middle of a heart attack, and that is life-threatening. I've seen it plenty of times where it's just, it's right there. Life is going on right there in front of you, and it may end. And so you have to be at the top of your game at 2 in the morning when you just drove in practically almost in your pajamas, you know, and getting there and realizing that these people's lives are on the line. So you are the person, you and your team basically are the persons who are going to save this person's life, you know. and to understand that sometimes you cannot, and things do happen where we've had people, you know, deceased on our table too. So, and that's a whole nother stress that maybe you need to think about too in any, you know, medical field of that nature. A lot of times, we are, you know, things to think about is we're standing there. We are standing in one place at the table with the doctor for the entire procedure. And you're literally doing this, or you're going here, or you might be turning around, and that's about it. You don't go anywhere else. You're sitting there for the entire procedure, standing. So, you know, if that's not your deal, cath lab may not be the place for you, unfortunately. But most hospitals do work a regular 8 to 10 hour shift. I have a rotating day off, so that's really good. Sometimes I get 4-day weekends, and that's been really nice. But in healthcare, you will work holidays. You know, there will not be a Christmas that you won't work. You know, somewhere, if it's not this year, you're going to work it next year, because you kind of rotate with your coworkers, exactly, on being able to get off. So also, you know, your job doesn't end at, you know, after 8 hours. If you've got patients there, you're going to be, you know, there with them until the day is done, basically. So that's the other thing. So let me show you that clip I have, and it'll give you a little explanation. Sorry, I'm gonna pull it up. It's a good example. Basically, I had a slide to show you a YouTube video, and it showed you all the cath lab and what it looks like in there, and basically what we do, just a general recap. So, exactly. So, anyway, we'll go back and we'll just skip over that, and I'll show you some other videos later without sound, because it's just the heart catheterization. But basically, we are going to go back to the drawing board here. There we go. I was trying to run that. Yeah. Well, I wanted to run it, but it wasn't pulling up the sound. Oh, okay. Because I don't know what he said. All right, so basically, I just want to talk about what I did in order to, you know, complete my degree and everything, and how I got into this. So basically, when I was in high school, I realized that I wanted to do a little something in healthcare. I didn't know what it was, and I was like, I don't really want to be a nurse per se, because I don't want to be dealing with patients day in and day out. The same people may be there for a week or two, and you just don't really know. So I was like, and then radiography kind of interests me in a way where I was like, well, that's, you know, I like x-ray, and taking pictures of bones and things would be kind of cool, but I don't know. And I just kind of went back and I looked at, you know, what interests me. And when I was born, I actually had a congenital heart defect. And so I lived my life going from cardiologist to cardiologist every year, getting checkups and knowing a lot about my heart. So basically it was really simple for me to go make that jump and actually say, you know what, I think I just want to I want to be in the cardiac cath lab. I want to be with the cardiologist. I want to help people that I actually, I know something about. I know these people. I've been on the table myself, so I can lend some kind of compassion, and I can, go to them and say, you know what, I've been here too, and I know exactly what you're going through, and I can help you, So it was really generally pretty easy to make that jump. From there, I went on to a 2-year college. I actually took a class, it was called Cardiovascular Technologist Program. It's a 2-year program, and they offered it at Houston Community College downtown. It's no longer there. It actually is only, like I said before, it was only about like 8 or 10 in the United States that actually do the program. Houston Community College, I guess they didn't have the funding for it, so they stopped after about 4 or 5 years. And I took my, degree, and I went into the work field. And I realized that as soon as I graduated, that really what I should be doing is getting my registry exam. And basically, the registry exam is a certification that says, I am actually certified to do this. And it's just like in nursing, because when you get out of nursing school or a radiology school, you are a radiologist, a rad tech, but you actually aren't certified yet until you take your boards. And so for me, that was just the natural step. It allows you to have a higher pay grade. The professionals, in your hospital actually, look for things like that for certifications. The more that you have, the better off you are financially and just respected, in your field. Because you can, for my field, you can actually function in a hospital setting without the actual certification, but it's just, it's recognition, it's, your self-esteem, that you finish this program, that you have this registry, and it really builds, confidence in your employer too, that you have what it takes to do this. So the registry exam is basically about the same as nursing. It's about 3.5 to 4 hour long test, if you can imagine. Sitting in a room, it's kind of tough, just like any other exam, but it's well worth it, The other things that we are required are the same as nursing and rad techs when you're in a cath lab or any hospital setting, is that you would be required to take the ACLS. ACLS is the advanced basic life support system that we have. So it's more advanced than CPR. Okay, and you learn how to run a code, a full-on code. And you learn what drugs to be given, at what times, and how to administer them. Even though I am not a nurse and I don't actually push drugs, you have to learn all those things for your ACLS. Because as a bystander, now I have a license, an ACLS card, and if I was going to stop and render help to anybody on the street, I am liable for what I do. If you, as a non-health person, go and try to save a life and you do what you can, you are not liable for whatever happens. You are trying to do your best. You are a regular citizen. But me, as a certified person, I better know what I'm doing. And if I do it, there are consequences to it too. So, that's something that you have to take into consideration and make sure that you pass those ACLS classes and you know your CPR very well. So there are some films that I did bring, and they are not associated with any volume, so that's good. And we can see. Oh, is that right? Mm-hmm. Okay. So right here. Okay. So and then you don't what? Yeah, you go on YouTube and then search for catheterization and then cath lab. couldn't get things started here. Sorry about that, guys. Anybody have any questions?
Do you enjoy your job?
I do. I actually do. For a short time, I had a job that was actually 8 to 5, which was crazy, ridiculous, because it was so much fun. It was like being on vacation. I didn't have to have any call whatsoever. And I sat there for about a year and a half in that position, and I missed being on call. I missed the excitement. It's like an adrenaline junkie kind of thing. When you get called out in the middle of the night, it can be a train wreck. You know, it can be really life or death. And I really got addicted to that rush because it's like nothing else, actually helping somebody and being on the brink there of death is, you know, it's pretty empowering. You know, it's a junkie situation. I'll tell you a funny story. Well, it wasn't funny, but you know, it's I'm chatting with my coworker, right? And here's the patient on the table, and we had just done a heart cath. He was clean, normal, everything was good. We're unhooking him, and we're about to put him back on a stretcher. And we're just chatting. Our coworker, he's across the way, and I'm here, and we're unhooking, the patient's right here. And we look up, and the monitor says that this man has just gone into VTAC, okay? Where his, you know, have you seen VTAC on it? You know, it's very distinct. You see up and down marks. And he's like, wait a minute, what, is this real? And we looked down, and I was like, hey, Mr., you know, and he didn't say anything. And I looked back at the monitors, and it was still going on. And I went down, and I went whack on his chest. And I did a precordial thump. I don't know if anybody is familiar with that. But if you're in a situation where that, you know, you see a man or somebody is, you know, not responding, I just gave him a big thump on the chest, and his pressures went back to normal. And I actually did it twice, and we were done. And it was pretty exciting. So, you know, right there, just boom. Wow. Yeah, as hard as I could, right on his chest. That's the funny thing.
Wow, that's pretty funny, actually. No, really, like, just whack on his chest and he's okay.
Yeah, I felt pretty proud of myself, you know. Yeah, didn't need to shock him, I just hit him.
You won't.
Dude, should I try out for this play? Oh my god! I'm on auditions today. My god, I'm going. Why are you wearing a suit?
Yeah.
You said I would.
We're gonna wait till the bell rings.
Now, Malcolm, is this where, what do you do with a cat?
So when we do a heart catheterization procedure, we go into the blood vessel with a needle and a guide wire and a small the vessels generally are soft. There's some calcification involved. We go in with a small but sharp needle.
Show me your floating table. I think this is amazing.
So the person is lying on their back typically, and this is called a floating table. And between the table and the image intensifier, which is the X-ray equipment, we can really get any number of projections in order to see the heart arteries, because the heart arteries are in a beating heart, and they extend over the surface of the heart like a root system.
You have to be a good Xbox or a PS360 in order to work this machine?
Yeah, who knew? We have a little trouble.
Yeah.
Probably my children may be better than I did.
Malcolm, this is fascinating. Now let's go back and see what some of the images show. Now, Malcolm, this is the image of the patient that's on the table right there.
That's the top of the catheter that I was showing you that we use. And then that's his arteries.
So show me which one of these are blood vessels and what's happening.
So this is the right pulmonary arteries. which goes to the right side and the underside of the heart. And this person has had some previously placed stents, so there's a stent here, and the stents look quite good, but now they've developed more blockage. So for example, this area.
Oh, I can see that. That's suddenly you got a really skinny area there. That's a blockage, an occlusion, you call it?
That's right. So we call it a narrowing or a stenosis, and that's due to plaque buildup. And that's somebody with a fairly tight blockage that's going to need to be treated with a stent.
Now, Malcolm, this is a coronary blood vessel that you're really looking at an enlarged view here of that same narrowing?
That's right. And this is from an image from inside the blood vessel called intravascular ultrasound. We can see very precisely the size of the blood vessel. We can see how much plaque buildup there is in terms of the percentage of blockage and the type of plaque that's inside the artery.
Now we're ready to go with the stent. This patient going to do well?
This patient should do very well.
That's it.